Okay, welcome back. So this is part two, looking at the use of spinal decompression. And so in this part, we're going to cover a little bit about sort of the application and the reasons that we do some of the things, and even some of the differences why we choose certain equipment. So when it comes to application, and this is where I encourage you to say, okay, you look at a piece of literature, and I used to have my hammer this to my students. I'm like, you can't just look at an abstract, right? You need to read the whole article if it's really of interest to you, because you need to see what the methodology was, because maybe they were doing, to use traction as an example, or decompression, maybe they weren't doing it on a split table, and that has a dramatic influence on the application and the outcomes, but also things like the intensity. So three main concepts when it comes to the application is comfort, sequence of events, and the frequency of treatment. So I kind of touched on these a little bit, and that literature shows us that these things do matter. And even just conceptually, if you think about what comfort is, it's pretty important if you think about the tissue that we need to get through before we do anything else, right? Which is the muscle tissue. And that's, whoever designed us, depending on your philosophies, that was pretty smart, because it's an active tissue and it can help guard for us. So I like to do step test or other metrics, and so I do locomotion assessment, and this is just one of the tools I use. And it's for a couple of reasons. One is I use locomotion assessment to sort of evaluate the overall aspect of the patient itself, and actually it helps to identify some of the generators that's causing their problem. But it also shows patients, as even when their pain is gone, they ain't right in that we still have work to do. So sometimes I use a step test, which is a walk in place, so to speak, that is pretty easy to apply. So this particular patient was a young patient, and was a volleyball player with acute low back pain, but she also has a history of low back pain, and so I wouldn't necessarily call it a brand new condition, but sort of an exacerbation of a chronic condition. So I like to use metrics, and again, for a couple of reasons. One is to show patients what's wrong with them. Two is to help identify, the approach I'm going to take when I'm treating patients. Three is to let me know that that approach is actually working. Four is for compliance, and five is for relative discharge of a patient, knowing that, we got to the level at which we're trying to. So this is just one of the metrics looking at flight times. And so we can see that, there's this linear climb effect, and this is on the right, flight time, step time on the right. And I didn't carry this all the way out, but it's quite variable, and that we see here, it's much more consistent. So what happens when you're in pain? Well, you're in acute pain, you're trying to find your more so antalgic position. And that's, that's a neurological deficit. So it's a motor control situation, which is why when it's not working right, the motor control system is not functioning appropriately, and you don't move as well. So what we see here, I use this, it's a covariance statistic, and fortunately looks like my video is going to cut out cycle time. But in any event, so contact time, flight time, pace or steps per second, also cadence. We can see that even if you don't know what these really should be, that we try and be somewhere around the 2 to 6% is a normal covariance. So we see her at 9.3, 17.4, 9.8. And the problem with that is that means she's not moving appropriately. And it's not rocket science, when you look at someone, but what we're able to capture from this is some of that baseline assessment. So this was actually right before decompression treatment, and then we can see after. And so what we see after is we see a reduction down to 2.8, 8.2, 2.0. So the time in flight is still off, but hey, for one treatment, this isn't too bad, right? And the reason is that, a lot of times patients experience a reduction in pain so significant that they're like, "Oh my God, you fixed me." And it's like, well, we still have some work to do. So we can still see that there's an asymmetry, especially in your flight and certainly in your um, which will also influence your step length and your strides and other performance factors. And again, this is even for normal walking, not necessarily for someone who's an athlete. So we can see the comparison and it's a dramatic change. So one, it says, hey, this was actually a really good treatment because it reduced all of those factors. And that's what I was sort of getting at too, was we reduced the mechanisms associated with what was causing her pain, which is why we see that co-commitment improvement in overall performance. So data is a really good thing, to show people. The components of treatment. So what do you use? And I'm going to just cover sort of the basics. So we look at static and intermittent, but we need to break these things down because historically, when you look at the research, these things matter. What was their progression phase like? What was the treatment? What was the regression? How long was it? What we find is when you just perform a straight linear progression up to the intensity, which historically was like 50% of body weight, that's going to be real challenging because it actually doesn't reduce motor neuron excitability. Not unless you're doing this for a whole extended period of time, right? And so we've got some other options. And then, should I be static or should I be intermittent is another question as to what it is, what would you like to do? So when we look at using a stepwise progression, in one of our studies, we actually showed that think about sort of incrementally increasing this workload and you get an adaptation. As a result of that adaptation, then we don't get an increase in muscle activity, which is actually what a lot of studies found when they were doing traction. And they're like, oh, well, traction's not any good because it actually increases. Well, it's because you did it wrong. I mean, you went and you tried to pull people way too hard, way too fast, right? Using this stepwise progression approach is it allows us to sort of reach steady state and then a time period for accommodation. And that's exactly what that is accommodation. So the body's going, oh, okay, that's cool. You're not going to hurt me. And this is a very natural course of process. And this is even in people that are asymptomatic, right? So studies show that just moving a limb causes an increase in muscle activity. It's not dramatic because it's more sensory feedback. It's the antagonistic muscle or the agonistic muscle going, agonist muscle going, hey, what's going on? So it's actually a neurological feedback mechanism that gives us overt control. And if you have some really good EMG studies, you can actually look at this in like Parkinson's patients or stroke patients initially after they have their stroke, and it's really interesting to see what this looks like. It gets all garbled up in the neurological system. So it makes sense that we need to make sure that we do that. Just by doing that, it actually reduces the treatment time dramatically to get to the point where we see a reduction in that motor neuron excitability, one of those neurological features that we're looking for, which reduces muscle tension. So that's really, really important to take into consideration. And that's one aspect. And then, when we're looking at the treatment, we need to basically understand that there is certain criteria. And I used to, have this discussion a lot of times with salespeople and product people, and it's like, in clinic we're dealing with humans, and unfortunately, they don't all respond exactly the same. So I've helped set criteria for people because people will ask me questions, and sometimes it depends on what your table design is, right? So if you all are using the same table with a lot of the same characteristics, so even as we were developing, when I used to be with Chattanooga, so you could see the table in the picture here. So that's the table I use now. But it was very important to me that in this development that the physics of this matched with the previous, because the 600 TRT or the TRT 600 was a gold mine in terms of treating such a wide diversity of patients because it had a very low coefficient friction of movement in the horizontal plane, which is real important, right? Because then we obviated body mass because we don't talk about that anymore. It's not, I should say, we don't, it doesn't need to be, right? We could be much more consistent with our approach. But also as I transition or I use a different table, right? So that way I don't have to mess around and make sure the patient's on the same table. But think about that in terms of like a chest press machine, you know, if they're using a Life machine versus a Cybex versus an Icarian, the pin's not going to be the same on all of these. So for this, it was not only the same, but what was most important is to have those physics features replicate that initial table, which was the design in and of itself that really changed the face of how we do that, because that's what makes the delivery consistent. But knowing what we know, it really increased the diversification of patients. Because historically, like I said, traction was, we pulled the crap out of people, right? I wouldn't do that, you know, today. And, you know, being a former athletic trainer, standing on the sidelines, sometimes we'd have people that were injured in the game. And I've had people on my table, you know, within a very short time period after that, even with acute disc herniations. Why? Because I wasn't pulling the crap out of them. I was getting the neurological benefits by very low intensity and having a table with a low coefficient friction and a retraction spring to it that was calibrated to the system. It actually allowed me to be that specific and detailed. Understand the clinical relevance, you know, why am I doing this? And I know if they come in with a spinal condition, you got a pretty good chance that you're on the right track. You don't have to think too hard about that. But, you know, if there is a hypermobility, then know that, no, you don't want to pull them too hard. But we do now have that opportunity today, knowing that you don't have to pull really hard to get those neurological effects. The patient responds to their signs and symptoms. So I never ask a patient, you know, oh, can you feel this? It's not about that. We have very poor two-point discrimination, stereoesthesia and graphesthesia in the lumbar spine to begin with. So by the time that they can feel it, you may be pulling them too hard. So it needs to be based on outcomes. And again, that's the benefit of using, you know, a system that you know, right, that is designed to be replicated from patient to patient. And I've been on other systems where just simply not having that low coefficient friction of horizontal movement, it dramatically changes. And now instead of, you know, sort of having that more consistent distraction force component to it, it wasn't consistent at all. And that changed, you know, you couldn't possibly deliver the same treatment to different patients without going through multiple trial and error treatments to see if it was actually going to work. Right? So that's why, you know, when we look at today's devices, they matter. And that's why I say to people, you have to know your device, you know, if you want to replicate that from patient to patient, which is really important. So today's devices are a far cry above, you know, even what they were 25 years ago, or even 20 years ago with what we know, because we can, you know, we can distract. That's not a problem. We always could, but being able to change the speed of the pull, being able to change the durations, the hold patterns, that low coefficient component was huge. But the design of the belting and securing systems also night and day, right? Because I mentioned earlier, you know, I felt like we were getting people ready to, you know, pilot a World War II plane and have to jump out of that thing the way that we were strapping them together. So one, it's much quicker, but the other reason that we can't just use patient response in feeling the traction is when you use a really good belting and securing system, it decreases the hot spot, so they don't feel it. So the securing system that you're looking at here in the picture, it creates a circumferential pull, so it doesn't asymmetrically load. So there's an anterior securing and a posterior securing system, and with the circumferential and the structure of the belting system so important that they don't feel it. And that's why, you can't just go based on, let me know when you feel that pulling, because it might be too late. You might pull them too hard and you won't know that till later on that day, or possibly the next day. So those are features that, again, make it really important. Um, Changing the speed of pull, and actually all of these features really allow us to do what some of us learn to do with our hands, right? And so initially when manufacturers are like, how can I improve something? Make it more intuitive, make it more like what I want it to do. And so instead of, just being a device that could pull the crap out of people, that let's make it something that can mimic what I do with my hands in long axis traction, right? The initial mobilization technique that I said that we start with, post-surgically or injuries. Basically, we can do that in the spine. And oh, by the way, why would I want to do that in the spine? Well, I love doing it in the shoulder. I love doing it in the hip. Well, the reason for the spine, remember that that's the central housing mechanism of the neurological system, and how it interacts with all of these. So changing the speed of pull effectively allows us, in conjunction with changing the duration patterns, we can really mimic some of these graded mobilities, right? So I know this is an MCP, a metacarpal phalangeal joint, but we can look at pre-manipulation, post-manipulation, and then post-manipulation and traction. Because I get a lot of pushback sometimes, like, well, I'm doing, manipulation. It's like, yeah, that actually has a lot of, good components to it, but it doesn't create any deformation in the tissue. So the laxity that it creates in the joint is very short-lived, because it really addresses the elastic components versus the plastic components that are influenced by something that is held for a longer period of time. And related to that, being able to do a pull pattern that we hold for only 30 seconds, yeah, that's kind of like the stretches that we recommend to people. So we know that that's actually long enough to create some deformation. So again, you're not being redundant by doing manipulation and traction or decompression. So we can adjust that speed in multiple areas, depending on what it is that you're trying to accomplish. So again, a lot of diversity in how we can create and develop our programs. Changing the duration, again, that goes back to sort of what many of us would do with our hands, and matches with Maitland's grading scale. I think I might show this a little bit later, but so grades 1 through 5. So a grade 1, they're sort of lower durations or longer durations, but not large amplitudes. And then grade 2s are more like shorter to medium duration, again, a little bit larger amplitude because we're trying to create a pressure differential by moving. And so imagine being able to do that with a device and walking away and either going to address another patient or, I don't know, grabbing a bite, grabbing a drink or something like that. In any way, being sort of that unattended therapy that otherwise it's pretty challenging to do these mobility patterns in the spine. We all learned them. You can use straps, but it's too much work. So just looking at and how we're actually able to facilitate those reactions that we're looking for in the neurological system, even without using our hands. Cool thing is, because these systems are using microprocessors, basically small computers in there, man, we can change this at the progression stages. We can change this even in the pull patterns. I can leave one at 60 seconds, put the other one at 10 seconds if I wanted to, or do 30-30 or 45-45, whatever it is that you're looking for. In fact, we can even go 0-0, right? So as soon as it reaches the peak intensity, it drops right back down, right, to the lower intensity. And then it goes right back up, goes right back down. So in other words, you're able to get oscillations. And depending on the intensities that you're using, you can actually create small gradients, or you can create large gradients, which actually we use intensity to determine the degree of mobilization. So again, a really interesting feature that we can do from an unattended perspective in the long axis, right, in a system that is housing the neurological components. The pulley attachments. So I've been using various table designs. I like the pulley attachment because it gives me a resultant vector. Well, anything will give you a resultant vector. But what happens is with the pulley attachment, it's a little bit more flexibility, and it gives you a resultant vector that results in more of a coupled motion effect, right? Versus putting someone into one position and then pulling them from that position in that horizontal. So the benefit of this is really I can put patients in any position. So I can put them in prone supine or side lying. If they're not comfortable sitting exactly flat, I put wedges on them, whatever. Know that, because of the pulley system, I can also use that to create a vector. So I can lay them prone or I can lay them supine and change that vector by changing the orientation of the pulley system. Right? So sometimes I want to match either an antalgic distraction force, or I want to create that coupled motion effect. So what we found in sort of addressing this in some different tables that we were using is the pulley systems tend to be a little bit more comfortable, if not a lot more comfortable for certain patients. And again, that flexibility in design, being able to position patients. Now, there are other table features, and I use a flexion distraction table as well. But I want to emphasize the fact that in distraction or decompression, that primary vector is long axis, right? Versus in my flexion distraction, yes, I can hyper position a patient into one position and then pull them. And that's very different than creating a coupled motion effect. Right? So this is a prone position, and the table's only going to move in one direction, but I can manipulate the position of the patient, and I can also change the vector of the pulley. So now you see I just lowered the table, and now that vector has changed. So now I have a different vector, and as a result of the way that the securing system works, there's going to be a higher moment of pull closest to the table. So what happens is the resultant vector and the way that I'm secured to the patients is in that prone position, we are going to get a slight anterior pelvic tilt. But when we're in the supine position, we actually get a slight posterior pelvic tilt. And the benefit from that is, especially in the supine position, which is typically my preference for pulling patients, because I give them some exercises that are up on the ceiling so they can see those. But what we get from that is, as the distraction force is increasing, we're getting that axial distraction separation. And because of that posterior pelvic tilt, we're also getting further opening of the posterior elements, right, and that lateral canal. So you're getting that coupled motion effect, which one tends to be, it's much more representative of how people typically move. And two, because of that, it tends to be much more comfortable. And because it's also going to be related to the distraction force, it helps me to further control the amount of mobility that I want to introduce into the patients. Split tables, without a doubt. So the studies that gave us 50% of body weight from two studies in 1980 and 1981, and they were done on a non-split treatment plinth. Nothing wrong with that, but then everyone was using that, and when you use a split table design with a low coefficient friction system, there's not the same resistance. The beauty is the only resistance is going to be sort of that internal tissue, versus when you pull someone across a treatment plinth that doesn't have a split to it, you have to account for their body mass and the coefficient of friction against that table. So using these split designs, it obviated the need for body mass and really was more directed towards what does it take. And so in 2009, the paper by Kolwicki et al., showed that in these types of systems, the amount of force that's required is very small. It's about 5 to 7 pounds of force required to create a significant separation between L5 and the sacrum. And again, remember, significant from a statistical standpoint might be a little bit different than clinical. So yeah, we're talking only, a millimeter or two, but at that level, I mean, remember that that's a 25% average increase in opening of the central and the lateral canal if it's encroached upon by soft tissue that we saw by SARI. So in any event, it's the same. So then it allows me to use very, very low forces when I'm actually going to be introducing this into the patient. And that's a cool thing because I can use this during that acute stage, which otherwise, we didn't before because we really had to pull people at really high forces and we didn't have the capacity to really control that as well as we do today. And that's just a joke, most people are like, why do you have to say, big words like that? Well, the coefficient of friction, it's the resistance between two surfaces, right? And so it's hugely important. It's so important that it dramatically changes based on your table design, right? And so find a low coefficient friction table design. The other thing that's hugely important is a supportive retraction spring, right? Because when you're attempting to perform intermittent decompression, you cannot do that, first of all, on a treatment plinth that doesn't have a split table design to it. And it's nearly impossible to do that even on a split table that does not have a retraction spring. Why? Because the tissue that we're distracting is not elastic enough to go back into its position. And if you think about what it is that we're doing and you create plastic deformation, it ain't going to go back anyway. So if you actually want to develop and create mobility, you must have a split table design, low coefficient friction to that horizontal displacement, and you're going to need to have a calculable retraction spring, right, that you can use to close that table back up to some extent. It can't be overpowering, so that's why a good design table has that all figured out for us. People, want to say, is there a specific poundage or intensity that you can use? And this dates way back many, many years. And the answer is no, because what we find is it's somewhat variable from patient to patient in that people have some differences in disc pressures. It's much easier when we're looking at compressive loads than we are looking at decompressive loads. So if you look at the study by Ramos and Martin in 1994, which is one of the first studies, looking at that VAX-D, another, again, split table design system to it, what we see is some people go negative even before we start. And that's just simply their capacity to create relaxation. And so we don't really know that starting point, and we don't really know at what intensity results in what degree of negative pressure, right, measured in millimeters of mercury. Here's what we do know is on these low coefficient friction design tables that you sort of reach that peak negative intradiscal pressure at about 100 pounds of distraction force. That we do know. So at least I know that if my goal was to create negative intradiscal pressure, there's no reason for me to go over 100 pounds. That doesn't mean I don't go over 100 pounds. It just means for that specific indication, right? The reason I will is based on patient outcomes and some of the other metrics that I might use in the performance aspect of knowing whether or not the patient is responding appropriately. And this is just, again, going back and referring to that low coefficient friction. So this is the paper by Wiki et al. So what I had done was, I take this information. It's like, okay, well, that's that. Now I need to know exactly what that means relative to my table design. So we actually studied this in the DTS system. We evaluated, make sure that the coefficient of friction of system is the same and that the spring retraction rate is also the same, which means that the intensity and the elasticity to that spring is the same from one table to the next. Now, if you've had a table for 20 years, there is what's called spring fatigue. So know that, that will change a little bit, but still even not dramatically. So in other words, your table starts to separate If you attach the cable system to the table, it actually starts to separate at about 15 pounds, between 10 and 15 pounds, right? And add to that your sort of 7 pounds. So you're 7 pounds to the 15 pounds, and you've got about 22 pounds. Now, I make a little bit of allowance for the fact that most patients come in. The reason I'm treating them is they probably have some level of hypertonicity. So that's why the starting point is somewhere around 30 pounds. So at 30 pounds being a good starting point for most people, one, I know that there's a therapeutic benefit. In other words, I'm actually doing something to them. Two, the likelihood of overtreating someone at that rate is extremely unlikely. So that means that almost regardless of their condition that otherwise historically might have been a contraindication, I'm actually able to put most of those people on my table. In fact, I've been able to put anybody on my table regardless of their condition, including stenosis patients. So knowing your system is real important to figure out what these sort of metrics are and what your limitations and delimitations are going to be. So this was an interesting case, and so this was a spinal patient, and hopefully you can see this well enough, but you can see the hardware in this particular patient, and I'll show you. I hope I put the A to P in here. And so a little bit of history. So this patient, 79-year-old male, extremely active, still working, in fact, former professional baseball player, and actually was at this moment in time was a scout for his organization. Just beat up, playing baseball. By this point in time, he'd already had 5 surgeries. So he was fused from approximately, I think it was T7, T8 down into the pelvis. And again, hopefully I'll show you the A to P here, into the pelvis. And he was also fused from C3 down to about T2. So not much left. So the question is, can you do decompression? Well, the actual initial question is, why is this patient coming in? This patient is experiencing pain, right? So when we fuse something, yeah, we're dealing with the mobility in the osseous junction, or I should say the hypermobility in the osseous junction, but one of the issues that we also have to contend with is, what about all those tissues that were designed to move and actually gain their nutrient and their livelihood from moving? So we see atrophy, and I mean, we see that just in sedentary people anyway. So what can we do for this particular patient? So anyway, this patient went in. He was on average about 8 out of 10 on the pain scale, and he's just like went back. They referred him back to the neurosurgeon, and they said, yeah, we're going to need to do another fusion. And he's just, no, I mean, there's there's not much left to fuse. So he has obviously, mobility issues, and he just doesn't want to go through another surgery. So comes into the clinic and is looking for, what can be done. So the question is, what could be done? And so thinking back to what we can accomplish as a result of the myoelectrical patterns, the nociception, and things like that. I can tell you that the mobility in the neurological tissue is one of the components that we found to be, sort of that neuroprotective, stimulatory, that makes its way, and because it's mechanical movement that results in opioid production. And so you do not need a lot of segments available to move if you're just trying to create mobility in the neural tissue. Right, and here's the A to P, so you can see those large screws in the pelvis there. So think about, some of the things, and I think back to, a lot of the cool work done by Stuart McGill, for example, in when, looking at and doing imaging studies on cadavers of people that reported with nonspecific low back pain. In other words, it wasn't identifiable, but needed to actually get in there to see exactly, because it's not picked up on imaging, these little adhesions to the ligamentous structures that are holding the nerve roots in place and limiting their mobility. And that causes problems. It causes further creation of scar tissue and dysfunctional movement patterns that result in nociception. And so, what's a great way to create mobility in those areas that are even fused? And a lot of us have been doing this anyway. May not see people to this extent, but doing it even in just a couple few segments, well, you're creating what's referred to as a neural flossing technique, right? And you do that just by doing traction. So mobility in the neural tissue is a wonderful thing. So anyway, the prediction was, with this particular patient, was there's something that we might be able to facilitate with this particular patient, and so that was kind of the intent. So let me show you here the cervical. So this is the cage in his cervical spine as well. So we performed cervical and lumbar distraction, not simultaneously, but within the same treatment sessions. And we explained to the patient that just providing mobility, one, was going to influence, the neurological components, decrease some of that hypertonicity in the muscular tissue that, you're not going to get in there and be able to stretch that out. Yeah, we could get in and do some soft tissue mobilization, maybe some shock wave or laser or something like that. But what's he going to be able to do on his own? Well, there are some home devices that people could use as well. But in the clinic, performing a decompression for both the lumbar and the cervical. Now, 8 out of 10 on the pain scale was just too much for him. He couldn't live with that. He couldn't work. He couldn't function, in his daily activities. So we said the likelihood we're going to get you back down to 0 is probably unlikely. But on discharge, and I believe it was about 6 weeks, a pretty consistent pain scale that fluctuated between 2 and 4 out of 10. That was more than acceptable for this person, especially not having to go in and have a surgical procedure that was done, and getting a relative pain scale that was, something that he could live with. So from then on, trying to do some things at home, but just really coming in on a sort of maintenance basis, was very worth it, because obviously there's some other things that we can do, while they come in for that, which, shockwave, for example, is something that has been shown to be able to be performed on a follow-up, which works really, really well for patients. So I show this case because most of all the cases, when people are asking, well, what's the protocol for something like this? There's some protocols that we do tend to standardize. Like there's no protocol for surgical procedures. The protocol is based on their condition, their dysfunctional component, just like an exercise or a movement. So we look at that because, remember, our end game is we are trying to, get people to move better. Certainly we are trying to reduce their overall pain, but that's where, kind of thinking out of the box. And that was, when the transition from ICD-9, especially to ICD-10, they were able to add some dysfunctional codes in there, which was awesome because it allowed us to justify and address, these dysfunctional movement patterns, dysfunctional segments and systems, other than just classifying it as low back pain. And I think back to that study by Ghost in 1998, where I said, they had patients that ranged from 18 to 77 years old. That's not the same patient, right? Even though they are classified, they both have low back pain, but they're not exactly the same patient, and we may treat them a little bit differently, which is why we probably do. We need to think out of the box just a little bit. Yeah, I'm a Marvels fan. So, what is our end game? So I keep saying this over and over and over again, that, the idea and for people that come to us, I think it's actually multifactorial. So for me, the end game is to get people to move better. What's associated with that? Well, moving better is also associated with other, situations that are going on with the other systems. If they don't move as well, they're going to succumb to some of these other problems, right? So immobilities that result in metabolic disorders, cardiovascular conditions, abnormalities in their movement pattern, even if they do move. Abnormal loading mechanics can result in progressive, degeneration of the various structures that are associated with ground reaction forces. So spine, hip, knee, feet, and things like that. So as I've said, my pitch to my patients is, let's get you moving as best as we possibly can so you can move, because the underlying premise to get people to move better, it's more functional in life. It allows us to also address all of those comorbidities. And as I tell my patients, I would much, 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 much rather treat you for an activity-related condition than a chronic condition. So I think we're going to kind of end there, and we're pretty close to my mark, especially between parts 1 and 2. That's my email address if y'all have any questions, or you can run it through Dr. Pete, however you guys want to do it. But anyway, enjoy the rest of your sessions, and I appreciate you all listening to me, and hopefully I provided you, I don't know, maybe something new, or at least some justification as to why we are doing what we're doing. Thank you. Take care.